Hello and welcome everyone for tonight's Just Ask from the EAO. Tonight, after a little too short summer break, I don't know how it will be for our expert tonight. We're going to welcome you back for our fall season of the Just Ask. And we start right in the middle with a true expert, a real big shot here in dentistry. We have Ignacio Sanz Sánchez here. Nacho, it's a great pleasure that you agreed. You were one of my wish candidates. So thank you for being here. First of all, thank you for being here. And the second question, how was your summer break?
Thank you very much, Stefan. And of course, thank you for inviting me because I know it has been your selection. So thank you. My summer was great. I had the chance to rest, maybe not as much as I would have liked, but at least I quit the clinic for 1 month, so it was amazing. I had the chance to prepare research, to work a little bit on my laptop, and of course enjoy the family.
Nacho, that doesn't sound like holidays. Prepare research and work on your laptop. But anyway, it's good for us. Maybe you worked a little bit on your presentation for tonight. I don't think I really need to introduce you. You got all your certificates from the Complutense Madrid University, one of the most famous university we have in dentistry. You have your master's degree, you have your PhD degree. You're an associate professor at the perio department. You also have your own practice, you lecture internationally and nationally, and you did so many great research. We also did some of the research together, at least some of the systemic reviews. So again, welcome here. Everyone is looking forward to your presentation. Again, welcome.
Thank you very much, Stefan.
So Nacho, actually, I knew that you're going to be here, and a case came across me, and it became a little bit of tradition in this Just Ask. Then I'm going to ask you as an introduction, what would you do? And look at that case. It's a central incisor situation. We have a dehiscence type defect. You don't see everything. You don't see an X-ray. But just give me your 2 sentences, because that is right into the topic we have for tonight. What should I do? Should I graft it? First of all, should I graft it at all? Some people say, maybe only soft tissue. And if I should graft it, should I use a particulate material? Or maybe a third question, and you have to answer it in 2 sentences. Maybe should I go staged? Yeah, was it maybe not the right decision? Just give me a quick idea of that case.
Yeah, I think in this particular case, I would go for a GBR. Absolutely.
So you think it was right to place it simultaneously? You would not have placed it staged?
It depends. It depends. Maybe if you're on your first cases, in such a difficult case like this, I would recommend to do an stage approach. Mainly because it's not easy to stabilize an implant in a good prosthetic position. I'm going to show you now in my treatment algorithm how the answer to these questions is very important. But if you are an experienced dentist and you can place the implant in a good position with enough primary stability, then I will go for a simultaneous and a GBR.
So I'm happy that you say maybe I'm a little experienced in that case, and I would go ahead. Thank you, Nacho, for that. Nacho, we have a lot of people already logging in for you. We have people from Cyprus, with people from UK, people from Venezuela, also from the Netherlands and Bulgaria. So they are all here and they're waiting for your presentation. And I asked you a quite difficult question for 15 minutes. I know it's difficult. Horizontal ridge augmentation, how do you do it today? And that's always what interests me and interests the people. How do you do it? Yeah. And as it is a little bit of tradition in this Just Ask, and you have agreed to, I will interrupt you whenever I think it's interesting, and whenever I think it would be good to discuss it a little deeper. And we are very much looking for your presentation. Nacho, please, the stage is yours. And if I'm allowed, I would interrupt you at certain points.
Absolutely. Absolutely, Stefan. So Thank you, everybody. I'm going to start. And as you know, after tooth extraction, several dimensional changes are going to occur in the bone in the three planes, both vertically and horizontally. And at the end, these changes are going to have a clear impact on how we replace teeth and how do we place dental implants. Today, I'm going to present an evidence-based treatment algorithm when we place implants on the heel bone. It may not be completely healed, but at least when we have achieved soft tissue closure. This means type 2, type 3 implants. So I'm not going to discuss at all, Stefan, augmentation procedures that we do together with immediate implants or socket preservation. So, as I've said, the first question that we need to make ourselves when we want to replace a tooth with an implant is if we are going to be able to place the implant completely surrounded by bone. And today we're talking about more or less 1.5 millimeters or more. If the answer is yes, then we can proceed with implant placement. But if the answer is no, then we need to think on a bone augmentation procedure that, depending on the anatomy of the defect, this may be horizontal, vertical, or combined.
Nacho, I already have to interrupt you. This is so interesting. Okay. If you are able to place the implant and you would have enough bone around it, and we're talking about the buccal, right? Yeah. Would you still think of a contour augmentation to sort of stabilize this buccal bone which you have on the back side of the implant?
I think if you have enough bone, this means 1.5 or more, and you don't have any aesthetic demand, then I think we don't need to do a further augmentation. Then if you have aesthetic demand because you need to compensate the contour, then you can go for a GBR or you can go for a connective tissue graft. We know about the studies by Jan Cousin that the results are going to be quite the same. So at the end, it depends if the patient agrees to have their palate as a donor site, or if they prefer to open a blister and use a bone graft and a membrane.
Great.
Okay, Steph, so once we have answered this question, then as we have commented on your case, then we need to evaluate if we're going to be able to stabilize the implant in a good prosthetic position with enough primary stability. Because if the answer is yes, then we can think on a simultaneous implant placement. This means place the implant and at the same appointment to do the bone augmentation procedure. But if the answer is no, then we should think on a stage implant placement. First, we do the augmentation, and then later on, we place the implant. So today, I'm going to focus on lateral bone augmentation. This means how we manage horizontal ridge defects. And if we come to the treatment algorithm and the treatment options, the main three options that we can observe in the literature are to use a resorbable membrane plus an space maintainer, that usually it's a particulate graft. We can also use a block graft that at the same time can be or not covered with a membrane. Or then we can use non-resorbable membranes or time mesh membranes that usually these membranes are going to be used also with a particulate graft that can be autologous or a bone substitute or a combination. So these are the three main strategies that have been described in the literature. Of course, we have many variations and many other possibilities, but the ones that we can observe in the main randomized controlled clinical trials are these. And of course, we need to say, and we need to answer the question, which one should I use? But I think that the answer to this question is going to be dependent on the type of defect, because it's not going to be the same to regenerate or reconstruct a fenestration or a dehiscence than a very narrow ridge. So the defect anatomy and the defect characterization, it's mandatory when choosing the procedure that I want to perform. And the first part is going to focus on fenestration and dehiscences. These are the defects in which the buccal portion of the implant is exposed with or without the coronal. and this is going to be the main difference between a fenestration and a dehiscence. The fenestration, we have the bone coronal to the implant shoulder remaining there, not in the dehiscence. And in this type of defects, when we look to literature, absolutely the gold standard today, it's to use a resorbable membrane and a particulate graft. We can discuss later on a little bit of the type of membrane, the type of graft, but for sure, the gold standard is to use a resorbable membrane and a particulate graft. And I would like to show you how I'm doing these cases today. This was the 3D implant planning. We were expecting to have a big fenestration there. It was not going to be easy to stabilize the implant, but at the end, we could do it. Here you can see that most of the defect, it's a fenestration tab defect. And at this point, we decided to do, I'm going to turn a little bit down the music. We like to use the sandwich technique, and this means to retrieve the autologous particles from the drilling, cover the exposed implant surface, and then to over-augment with the proteinized bovine bone mineral that we know that has a very slow resorption rate. And then everything is about stabilizing the particles with a membrane. If we use a collagen native membrane, then we're going to fixate it with titanium pins. We can also suture the membrane, and then in every GBR procedure, flap managing, it's mandatory, and we need to achieve a passive closure of the flaps. And to do it, we need to release the periosteum, release the flap, release the muscle insertions, and to be able to displace coronally that graft, that flap that needs to completely cover the membrane and the graft.
Nacho, I have a question. Very nice case. Is there any specific reason for not placing a DBBM material directly on the implant surface? Is that a concern, placing the DBBM on the surface, or do you think the autologous bone has more biologic capacity?
That's a very good question, because if we look to the literature, the systematic reviews, they don't see any difference.
That's why I'm asking, Nacho.
They don't see any difference in this type of defects. So maybe sometimes it's a matter of believing. Okay. We know also from the histologic studies from Pablo Galindo that the mixture of DBBM and autologous bone gives the final bone a little bit higher cellularity. But at the end, if we look to the efficacy of the procedure, there is no difference at all. And in most of the systematic reviews, they are mixing in the same group the patients that they are receiving autologous plus DBBM or just DBBM. So,
but to be a little accurate, you're not mixing it in that case. You do it a little bit like Danny Buser does it, right? Autologous bone on top, and then pure DBBM over it.
Yeah, absolutely. But I have to say that if I need to go to a second area to retrieve the bone, I don't do it.
I got it.
So I just got it from the drilling.
Okay.
Okay. Mm-hmm. And look, this was the re-entry, a very nice result 6 months after doing the procedure. And we need to be patient. At the end, we know that DBBM takes time to heal and to become bone. So don't be in a rush if you want to make these procedures predictable. And this was with the provisional restoration. I have to say that in our department, we have tried to do research also on the type of membrane. So we have tried to see if we have alternatives in terms of membrane. And I would like to share with you this very nice multi-center study in which we compare polyethylene glycol membrane that is like a gel to the native collagen membrane that it's the gold standard in these procedures. Here you have a case just to represent the type of a randomized controlled clinical trial that we did. This was a dehiscence type defect. In this case, we used a synthetic graft that was tricalcium phosphate and hydroxyapatite. And this was the membrane. The idea was that by using these gels, we could make GBR much easier to every dentist, because in these cases, you didn't need to fixate the membrane, to trim it. It was just applying the membrane at the end. This was the result. Sometimes the membrane acted as like a strange foreign body, and we have to retrieve pieces of the membrane. And as you can appreciate the case, it was not amazing. We had a residual dehiscence, and at the end, this new membrane did not perform better than the control, the gold standard. And we observed that at the end, it was even more difficult to place this membrane, because we need to open very big flaps, to have everything very dry, to be very homogeneous. So at the end, I have to say, Stefan, that it was a little bit nightmare. And indeed, this membrane never came into the market. It was not released at all. We have also tried to evaluate new collagen matrices that are more flexible. And in this multi-center randomized controlled clinical trial, we compared the gold standard to another native collagen membrane that incorporated elastin. And at the end, when we looked to the 6 months results, there were not a statistical significant difference in terms of defect resolution. This means how I am able to reduce the dehiscence. And you can observe that whereas the control in gray reduced around 60%, the new membrane reduced around 80%. Even though there were not a statistical significant difference, the residual dehiscence at the end of the study was almost double in the control group, 1.7 against 1 millimeter. And to illustrate, I would like to show you this clinical case. This was a challenging case to do it simultaneous. Maybe here, if you're not very experienced, I would go for an stage procedure, but nevertheless, we were able to place the implants in a decent prosthetic position. We did some corticotomies in order to increase the blood supply in this very hard bone, very cortical bone, and how we perform the sandwich technique with the particulate bone particles covering the implant surface, then the DBBM, and in this case, we used a double layer membrane that it was fixated with titanium pins. This was the double layer suture with internal mattress and single sutures. This was the 6 months CBCT that was taken because the patient also received a sinus floor elevation. And this was the very nice results 6 months after surgery, in which we can observe a complete defect resolution and a nice amount of buccal bone. We are also exploring slow rate resorbable membranes. These are membranes that last for 4 to 6 months, even being resorbable. I would like to share with you one case. This was a very young patient that experienced a vertical root fracture. The tooth had to be extracted, and at this moment, we perform a pediculated connective tissue graft in order to compensate the tremendous collapse that was going to occur due to the big defect that this tooth presented. We suture the connective tissue graft with its pedicle, and here we don't wait until everything is healed. Here we go for a type 2 implant placement, and this means when the soft tissue is already healed. If I know that I'm going to need a GBR procedure, I don't wait 3-4 months. I just go to it for it once the soft tissue is closed. This was the defect. It's close to your defect, Stefan. And in this case, we decided to place the implant, and to do the simultaneous GVR. In this case, I didn't place any autologous bone because from my drilling, it was almost drilled. All the implant preparation was done in the defect, so I barely get any particulated bone, autologous bone. So I went for DBBM, and in this type of membranes, they tend to tear if we try to fixate them with pins. So it's a little bit more tricky, the management, because we need to, as you can see in the picture, do a periosteum suture, but the suture that comes from the buccal periosteum to the lingual flap fixates very nice the membrane. Of course, this
Nacho, if I can interrupt quickly,
yeah.
Some people say who are experienced more with these cross-link membranes, they say because of the cross-linking, you may not need to stabilize them. What do you think about that?
Yes, absolutely. I think that they last so much time that at the end they do their function. I think the stabilization is just to have a more stable situation of the bone particles in the coronal portion after suturing that the stabilization itself of the membrane.
That's a very good point. I think the disruption of the particles by flap closure or swelling, like the Zurich group has shown, like this is maybe an important point for stabilizing it, right?
Yeah, absolutely.
Good point.
This was the closure. We wait 6 months and look how the membrane remains there. Little bits of membrane, and with these membranes we are able even to have 5-6 millimeters of buccal bone. Of course, this is DBBM and it takes long to mature, but that's bone and that's hard bone. And this was the management in the second stage. We try to be as minimal invasive as possible, and I did a pedicle flap just to augment a little bit the contour without any connective tissue, and this is the results 4 years later with an unstable situation. And today we have also an alternative that biologically tries to obtain the same, but without using the membrane. And this has been described very nice by Trombelli and his group, and is the SPAL technique. And basically, they are mixing a couple of flaps. First, a split thickness flap, then the periosteum is released full thickness, and the periosteum is used to stabilize the particles, the bone particles that we use, but without using any membrane. And the difference between this and a flap is that the periosteum in the flap is very mobile. In this case, by applying this technique, I encourage you to read the paper, if you have not already done it, is that you have a very stable periosteum that is not going to move and is going to maintain the particles at the end where you want them to be.
So it's like a double split, and it's still anchored on the base of the flap, right?
Yeah, yeah. It's a very nice technique. So, but as you can see today, we have also alternatives. And some years ago, we tried to evaluate which was the effectiveness of this type of procedures. And when we looked to the results of this systematic review that was published in Journal of Dental Research, we observed that if we want to have a mean value for how much we may expect to reduce the dehiscence, the meta-analysis showed that it was around 4 millimeters. As it usually occurs, it was greater on case series. It was less when only autologous bone and a resolvable membrane.
Nacho, is that simultaneous or staged?
Simultaneous.
Yeah.
And it's also remarkable, and it was a very nice finding, that most of the procedures perform the use of a xenograph and a resorbable membrane. And this is very consistent in the literature. This is the reason why today we can say that our gold standard in this type of defects, the dehiscence and the fenestration, it's the xenograph and the resorbable membrane. Now we're going to move to narrow reach defects, because these defects are so narrow that we think we need to think on an stage procedure. And if we think on a stage procedure, we need to understand that we're going to perform the augmentation procedure. We're going to wait 6 months at least, and then we're going to place the implants. And of course, if we look to the treatment algorithm, again, we can try to use a resorbable membrane and a space maintainer. Let me show you this case. You can appreciate that there was no vertical defect at all, but it was a very, very narrow defect with a very big concavity. So here is very difficult to place the implant in the right prosthetic position with enough primary stability. This was the type of defect. In this case, I used a synthetic graft. And in this particular scenario, Stefan, is when we mix the autologous bone, if we have it, with the bone substitute. Okay, we may use different proportions, the 20-80, 50-50, or even 100% of bone substitute.
So what is your algorithm there? The more the defect is out of the housing, the more you mix it with an autologous bone? Is that how I understood it?
No, I think the more I need to go outside the bony envelope.
That's what I say, out of the housing of the bone.
Yeah. Then I'm going to rely more on the xenograft.
Okay. Mm-hmm.
Okay, so we know that everything, and this is something that we need to evaluate when looking to a defect. If the defect is inside the bony envelope, then the predictability is very high, and we can use any type of defect of graft, of xenograft, allograft, synthetic graft is going to work. And again, the role of autologous is still a matter of debate. Yeah. But most of the randomized controlled clinical trials today that are performed, they use a little bit of autologous bone. Sometimes they even try to be 50-50. It depends. But in this scenario, the more you need to go outside the bony envelope, then the more you're going to need a slow rate resorption graft.
Because of the contour, because you are concerned about volume shrinkage, which may be more because of the autologous bone. And the more you go out of the housing, the more you want the container effect of the DBBM.
Absolutely.
I got it.
And in this case, we use cross-link membranes, and it's very nice because don't ask me why, but it was the situation. In the middle portion, I didn't cover the particles with the membrane. So, and you're going to see the effect of the membrane in this particular case. This was 6 months later, and you can appreciate that in the middle portion where I didn't place the membrane, there was a little bit of collapse. I didn't achieve the same amount of bone.
But still not so bad for no membrane.
Yeah, it's not bad. Yeah, it was in the membrane side, it was more than 1 centimeter of bone. And in the non-membrane, at least there was enough bone to place the implants. And you can appreciate on the top right that the membrane was still there 6 months later. I remove all the membrane remnants and I place the implants, and here we have the 5-year results.
That's true. It's also what I understood. The more complex the case is, the more you go out of the housing, is the more you prefer a cross-linked membrane. Is that how I could understand it?
If I'm going in this size of the treatment algorithm, resorbable, then I'm going more for a cross-link and DBBM. If you really want to increase thickness and you are on a very aesthetic demand case and you want less resorption of what you get, then maybe a non-resorbable membrane, it's preferable.
So let me ask you a little bit of polemic question. Sorry for that. So is there any reason for using a not cross-linked membrane?
Yes. If the defect is self-containing.
But would there be any harm when we use a cross-linked membrane?
The problem of cross-linked membrane is that soft tissue likes doesn't like it as much as native collagen, and you may sometimes expect some swelling that you don't see with the native collagen. But
Okay, get your point. So it's because of healing capacity.
Yeah.
Okay.
Okay. So as I was telling you, if we are in a very demanding aesthetic case, in a very challenging defect, then we may go for a titanium reinforced with a particulated graft. Let me show the case. This was a patient that had the 4 upper incisors, non-restorable, with endo problems, with caries, and we decided to extract them. We wait 6 weeks, and this was the big, huge defect. And in this case, in which you have a huge horizontal defect, you need a lot of bone augmentation. You need no shrinkage at all due to aesthetic reasons. And even if you have a small, also vertical defect, then the choice of a non-resorbable membrane, I think, may be a good idea. This is what we did. We managed the flaps. In this case, I only used DBBM. I fixed 2 titanium reinforced non-resorbable membranes. You can see here how we managed to close the flaps. And in this case, I wait 8 months. Clinically, it looks very nice. And look in the second stage surgery for implant placement, how after removing the membrane, the amount of bone was very nice. This was a very vital bone. You can appreciate how it bleeds, and it was completely hard. Here you can appreciate. There was no smooth layer at all. And how we proceed with a guided surgery. Drilling was hard, so it was a very nice outcome in terms of bone. Vital, completely vital bone. We observed it because it bled a lot. And this is the bed preparation with a very nice contour. You can see that we didn't have any collapse at all that we may expect if we use a resorbable membrane. This was the pre and the post. Then we had to recover again the vestibule depth, and we use a collagen matrix that has been designed to augment keratinized mucosa. This was the healing, and this is the pre, the post after the provisional restoration, and the 4-year result with a stable situation from the soft tissue and the hard tissue point of view.
That's a great result. Congratulations. I have a question. You said a little bit in between the sentences that you had no smear layer, and I think this is quite important because we are seeing these smear layers. We had Massimo Simeon here, of course, one of the pioneers of Teflon membranes. Why do you see that there is no smear layer? To be honest, I also see them in some of my cases.
Yeah,
you see them, or you have any reason for avoiding them?
No, of course I see them in most of my cases, but in this particular case that was mainly horizontal and not non-vertical, I think that it was one of the reasons why we didn't. Maybe the smear layer was so thin that I didn't appreciate it. But in the more challenging the vertical defect is, the higher I see the smear layer. Today, the non-resorbable membranes are changing in the sense that they are not occlusive at all, and they even have perforations to allow the penetration of the nutrients and also the cells. And with this change, also the amount of soft tissue over the augmented bone is being diminished. So I think that in this particular case, the reason was that the defect was mainly horizontal. So it was not that challenging in terms of bone augmentation.
But still, I'm happy that you also see some of the soft tissue under the membrane.
Absolutely. And sometimes it's quite big.
Yeah.
And then, of course, in the literature, block grafts have been used a lot, but I have to say that maybe today is not the first choice, especially if we're thinking on autologous blocks, because we may have alternatives less invasive. Nevertheless, our group has also tried to evaluate bone substitute blocks. This was the publication from my good friend Alberto Ortiz Vigon that tried to evaluate a novel collagenated xenogenic bone block for lateral alveolar crest augmentation. Let me show you the case that was performed by him as part of the clinical study. Here you can see the clear buccal collapse, the clear horizontal defect, the amount of bone in the horizontal coronal portion is very reduced. So in this case, we decided to perform an stage approach. And the technique would be mostly the same than if we used an autologous bone. So at the end, the raising of the flap is quite similar, a full thickness flap. We need to manage the soft tissue, so we need to release the periosteum to have a very passive mobilization of the graft. Then the next part is going to be the bed preparation. This means that the part of the bone that it's going to receive the graft needs to have a good position and a congruency with the graft. So we need to flatten it. So the portion in contact with the block graft it's greater. Then another of the key factors when doing block procedures is the complete immobilization of the graft. In this case, we use a screw. One screw was enough to stabilize the grafts. This was the second graft. Again, I have to say that the technique is the same if we use an autologous graft. Then literature has shown that if we cover the block graft with a collagen membrane, then the resorption of the graft is going to be less. And another very important key factor is to compensate the irregularities that we found between the block and the recipient bed with another graft. In this case, we used a particulated xenograft. So we overbuilt everything as we do with conventional GVR and particulated bone, and then we stabilized the membrane. In these cases, the membrane's role is to protect the graft from resorption and not the immobilization of the graft, because the graft is immobile itself. And then we go for the closure of the tissue that it's common to every technique that we use in GVR. This was the reopening. The result was not good. It was not bad. It was not amazing. At the end, I have to say that maybe 6 months is not enough to have a complete healing of these xenograft blocks. Maybe we need more than 6 months, but it was enough to place the implants, and this was the pre and the post after using these blocks. We have also tried to evaluate the effectiveness of the stage regeneration, again in the same systematic review that I presented. And when we look to the results, again, the number of 4 is the number of magic. So because we can expect a mean gain in the horizontal width of around 4 millimeters. Here, in this systematic review, the greatest gain was seen when an autologous bone and a xenograft were placed together with a resorbable membrane. And by 2015, that was when this study was done, more of the studies were focusing on bone blocks. Today, the tendency is completely opposite. Also, for horizontal stage augmentation procedures, the use of particulated graft and membranes, it's preferred over the bone blocks. Of course, we can use bone blocks. Of course, we have the Curie and the Luca de Stavola technique, but the tendency is to go for particulated grafts. And finally, we cannot forget that the learning curve is very important in this type of procedures. As I have said at the beginning of my presentation, if we have a complex case, maybe it's not the case to start with a simultaneous approach. I encourage people to start with very easy things, contour augmentation without dehiscence, then fenestrations, then dehiscence, then knife edge type defects, because we need to keep in mind that these procedures are subject to complications. And these complications sometimes can be serious and may not be as mild as just an exposure of a little piece of the collagen membrane. This is the reason why diagnosis, treatment planning, and execution in this type of procedures is crucial to have a happy patient and to get very nice results. If we achieve it, then these procedures may be suitable with long-term per implant stability. So I think that this slide, Stefan, is very important because we need to highlight that all these steps, all the learning curve is very important when doing bone augmentation procedures. I hope you have liked it, and of course now I'm willing for the discussion, the questions, and the debate.
Nacho, that was amazing. Thank you very much. I learned so much. I have so many questions still in my head, and you have a German-Swiss timing. This is amazing. I mean, on the minute. Thank you for that, Nacho. Amazing. I applaud you. I also want to tell the people you're one of the chairmen of the EAO Annual Congress in Milano, 24th to 26th of October. So please, everyone, if you have not registered, do it. It's going to be a great congress. You also see Professor Sanz Sánchez there. Nacho, there are many questions from people all around. There are people from India, from Berlin, from Paris, wherever. I would like to start with one very nice question, which I like very much, and which I sometimes, you maybe follow sometimes the discussion on social media, and also we have some lecturers telling us the DBBM regenerate bone is not a real bone. It is sort of an artificial bone, and sort of it will not work. The only thing is autologous bone. What do you tell these people? I mean, it's probably, you cannot answer it with research because the research is very clear, but this is a question from one of the observers, which I think is a very good question. So what do we tell the people saying that DBBM material or particulated replacement material will not create a real bone?
Well, that's a very nice question. And I have to say, Stefan, that of course, if we look to research, then all the histologic studies tell us that it's real bone. There's no doubt of it. But the problem is that it takes a lot of time. And by saying that is that you may have bone, but in order to have major bone, you need to wait a lot. You need to wait really a lot. Clinically today, there is no sense to wait 1 year to do a re-entry procedure in this type of situations to see the good quality of the bone. So usually
but do you think it's different with autologous bone, with the shell technique or whatever? You also have to wait.
Yes. Yes, but with autologous bone, we know that the bone is already healed after 4 months. And even if we wait more, then it collapses more. But autologous bone works if we are augmenting within the bony envelope. And it's clear, even the gurus and the most skilled people using autologous bone blocks, that if we need to augment above the bony contour, then you need to use DBBM in order to get a good contour.
So or you need a shell.
Yeah. But even if the shell is outside the bony envelope, then at the second stage surgery, they place DBBM and a collagen. So clinically, of course, DBBM is the gold standard, and something is not the gold standard by chance. I mean, this is a reality. But
Very, very good. Very clear point. I think it's very helpful.
Clinically, what I recommend the people, I mean, you and me that are going to do a presentation on this topic, we need to open big flaps, take pictures to show people if things are working or not. But clinically, if I'm doing a case with DBBM, I don't need to go full thickness. I don't need to interrupt the healing that it's occurring coronally and that it may last for 1 year. So where I recommend people is that in the daily clinic, if they're doing a second stage after an augmentation, a simultaneous augmentation of a dehiscence, they go almost a split thickness to find the cover screw and place the healing abutment or the definitive abutment. They should not do a full thickness in the most coronal portion, because if you want that bone to be bone and to be very stable, then you need to wait for 1 year or more.
Very clear. Staying with the timeframes, there's a question from Meshari. Can you elaborate a little bit of the time frame? I think it goes a little bit of the question, how long do I need to wait? Can you give us a rule of thumb? I remember Dennis Tarnow told me always it's 1 millimeter bone formation per month. I'm actually using that a little bit. What are you doing?
I'm doing, if it's a small dehiscence type defect, like 3 or 4 millimeters or less, then I'm waiting 4 or 6 millimeters. It's depending on, and I'm going to go back to the bony envelope. If my exposed implant surface is inside the bony envelope, and we can discuss a little bit about this topic. Today, I'm using mainly allografts, okay? And I know that allograft heals faster than a xenograft. So in these cases in which I'm completely within the bony envelope, I'm waiting around 4 months. If I have the opposite situation and this is an exposed implant surface that it's outside the bony envelope, then I need to rely on DBBM. And in these cases, I'm waiting at least 6 months.
In particular, if you work with the cross-link membrane, I guess, right?
Yeah, absolutely.
Nacho, there's actually a question which really fits in nicely here. There's a question about the dehiscence and the fenestration, the thing we already discussed, putting autologous first. The question is, could I also replace the autologous with allograft? Sort of first put a layer of allograft and then a layer of DBBM?
Yes, you could. You could. At the end, the allograft is also osteoinductive. Maybe the autologous has also the osteogenic capacity, but of course, you can do it that way. And I have used that way also in many of my cases. If I don't have autologous, then the first layer usually is an allograft. But yeah, always, if this implant is inside the bony envelope, if it's from the beginning outside the bony envelope, then I go for xenograft.
There's a nice question also, a little bit more philosophically. So are you still using block grafts or shell augmentations like Curie techniques? Is there any indication for you?
Yes, I'm mainly using the shell technique or non-resorbable membranes for vertical augmentation, but for horizontal augmentation today, I don't find the case. I think I can manage it in most of the cases with a cross-link membrane if it's demanding, with a native collagen if it's an easy case, and even with a non-resorbable membranes if I need a lot of contour.
Perfect. No, we're thinking the same. That's amazing. Because I sometimes think of when I see my knife edge cases and then I'm using a membrane, then I think, well, a lot of people will tell me, Stefan, this is a Curie case. I mean, go back to your textbooks. Great. I think I see it the same. There's a quick question about provisionalization. I think it's a topic because you will see swelling. You don't want to have pressure. maybe just 2 sentences on provisionalization. Is there any situation where you leave out provisionals? Is that also what you sometimes do?
It happens to me a couple of times every year, but most of the patients do not agree to leave them without anything. So my recommendation, of course, if the defect is affecting a small amount of teeth, then I try to go for adhesive provisional restorations. If the case is more challenging and it's more extensive, then I recommend to leave teeth or a fixed provisional restoration, even if we're planning to extract them at the end. Because if you do a metal reinforced provisional, an acrylic provisional with metal, then even with teeth that have lost 80% of the periodontal attachment, they can serve to support a fixed provisional restoration that I think that is the best alternative that we have when we're doing bone augmentation. Of course, sometimes I don't have teeth, so I try to use implants if I have them. And in the more extreme cases, if I don't have teeth and I don't have implants, I'm using today transitional implants. These are very, very narrow implants. They are like 2.5 millimeter diameter implants that they help me also to bond a fixed provisional restoration.
Perfect. Thank you, Nacho. There's so many questions. We're already a little bit over time, but I will maybe have 2 questions left. And I always want to have the last question. There's one question which I like. Does the thickness of the collagen membrane make a difference for you? I mean, they're interesting enough. If you look at the different companies, some of the collagen membranes are quite thick.
Yes. Yes, some of these membranes were designed for as soft tissue replacement, okay, and soft tissue substitutes, and then they realized they could also be used as membranes for GBR. For me, the thickness is not that important. I think that it's more important the resorption rate. And again, everything that it's inside, and you can see that I'm insisting a lot in this concept. Everything that it's inside is going to heal fast. So in this case, even if you're using a thin membrane, it's going to work. But every time you're going outside, then you need slow reception rate membranes. And I think that the thickness is not going to influence the resorption rate. So, of course, they can be used. They work. They have been explored and evaluated in RCTs, but I think that does not make a clear difference today.
Great. So the very last question, I would like to give it a little bit with the question of the participant together. There's the question, when do you use pins and when do you rather use anchoring sutures? Maybe you can integrate that a little bit. My question would be, Nacho, a lot of fuss is been discussing now how to mix up the bone graft, sort of using PRF, using hyaluronic acid. We sometimes hear about sticky bone, that it is important to sort of mechanically already stabilize the bone. Also, Danny Boozer does it with the blood concentrate. How important is that for you to sort of stabilize the replacement material per se? You understand my question?
Yes.
And if you want, just maybe also give a quick answer to when do you use pins and when do you suture a membrane.
Okay, so the first answer is going to be I barely pin today. Most of the pins that I place is when I'm using non-resorbable membranes, and in these cases, usually I'm doing sedation, so the patient is not going to remember that I have used pins with them.
Good.
So in most of the cases, I'm using periosteal sutures.
Mhm.
I'm also using today, as an alternative to pins, micro screws.
Tenting.
Not tented. These are like 3 millimeters screws that they are like you don't need to prepare any nothing the bone, so they're like self-screwing, and they work very nice because you avoid the hitting with the hammer.
Mhm.
So this is another alternative that I'm using today, but I barely pin.
Mhm.
And in regard to the biologicals that we have today, I'm using every day even more LPRF and the sticky bone. The reason is how I manage the graft. It's really fast and it heals very nice for the soft tissue. But I don't think that these concentrates are going to have an impact on how stable is the bone in the coronal portion, because at the end these products are going to resorb very fast. So I think it's a matter of how you manage, how you control the graft at the beginning, and that's all. But I think that they're very useful.
Perfect. Nacho, that was amazing. We have still so many questions open. So, Nacho, I'm sorry, we have to get you back here. It was amazing. Chapeau. I really loved it. I learned a lot. I knew you're going to make an amazing presentation. So if anyone has not enough from Nacho, you will also see him in Milano, 24th to 26th. Of October, the EAO Annual Congress. Please go there. Please register. It's going to be an amazing program. It's an amazing city. Everything will be great. Nacho, that's it. Enjoy your evening. I heard you had a crazy day with a lot of surgeries, rescheduling of patients. So I think you're also happy. A lot of people thank you. Thank you for the amazing presentation. Thank you. You will have to read the comments later. A big thank you on behalf of the EAO for making this happen for us. A big thank you from my side. Nacho, thank you very much. It was really a great pleasure.
Thank you very much, Stefan, for your kind invitation. I have enjoyed. I would like to thank everyone that has been behind the screen on Monday after summer break and even very late at night. So thank you again. It's always a pleasure to do things with the EAO and with good friends like you. Thank you, Stefan.
Thank you very much. So do I. All the best. Greetings all around the world. Say hello from Madrid, here from Germany. See you next time. And thank you again, Nacho. Ciao, ciao.
Thank you, and see you in Milan.